Okay, so in Chapter 7, we'll be going over airway management. Per the National EMS Education Standard competencies, it applies the knowledge of fundamental depth and foundational breadth of the general anatomy and physiology to ensure a patent airway and adequate mechanical ventilation and respiration while awaiting additional EMS response for patients of all ages. So within the scope of the EMR, or emergency medical responder, we will cover airway anatomy, airway assessment, and techniques to ensure that patent airway, physiology and pathophysiology of respiration, pulmonary ventilation, oxygenation, respiration, external, internal, and cellular. Two of the most important life-saving skills is airway care and rescue breathing. The ABCs of life-saving skills is airway and breathing. So respiration, we're going to cover anatomy of respiration, assessment and management of adequate and inadequate respiration, supplemental oxygen therapy, and then of course over to artificial ventilation, assessment and management of adequate and inadequate ventilation, artificial ventilation, minute ventilation, alveolar ventilation, and effective artificial ventilation on cardiac output is a mouthful. We're going to look at anatomy, signs and symptoms, and management of respiratory emergencies, including those that affect your upper airway and your lower airway. You'll see on this slide there is a diagram or a picture of the upper and lower airways and different components. Parts of the body used in breathing is the mouth, the nose, the throat, trachea, lungs, diaphragm, and numerous chest muscles. To maintain life, all humans must have food, water, and oxygen. Lack of oxygen, even for a few minutes, can result in irreversible death or damage or death. If brain cells are deprived of oxygen and nutrients for 4 to 6 minutes, they begin to die. Those cells begin to die. Brain death is followed by the death of the entire body. The main purpose of the respiratory system is to provide oxygen and remove carbon dioxide from the red blood cells as they pass through the lungs. If a patient of ours is not breathing on their own, we have to breathe for them to perform that gas exchange. In an unconscious laying on his or her back, the passage of air through both the nose and the mouth may be blocked by the tongue. The tongue is attached to the lower jaw or the mandible. A partially blocked airway often produces a snoring sound when the patient is trying to breathe. Other parts of the respiratory system at the back of your throat are two passages, the esophagus, which is the tube through which food passes, and the trachea. The epiglottis is a thin flapper valve that allows the air to enter the trachea but helps prevent food or water from entering the airway. And then below the trachea we have where the airway divides into bronchi, two large tubes supported by cartilage that lead to the lungs. And then the two lungs are located on either side of the heart, left and right, and are protected by the sternum at the front of the body and by the rib cage at the sides and the back. Other parts of the respiratory system, we have our smaller airways that branch from the bronchi, are called bronchioles. The bronchioles end as tiny air sacs called alveoli. The actual exchange of gases takes place across a thin membrane that separates the capillaries of the circulatory system from the alveoli of the lungs. And we'll back up here and take a look at this image right here. That thin membrane that covers these alveolar sacs and the capillaries of the vascular system, or the circulatory system, is where that gas exchange happens. An exchange of oxygen and carbon dioxide that occurs in the alveoli is called alveolar ventilation. The amount of air pulled into the lungs and removed from the lungs in 1 minute is called minute ventilation. When a patient is not breathing, artificial ventilation is necessary to supply oxygen to the heart and the rest of the body. Lungs consist of soft, spongy tissue with no muscles. Movement of the air into the lungs depends on movement of the rib cage and the diaphragm. When the diaphragm contracts during inhalation, it flattens and moves downward. On exhalation, the diaphragm relaxes and once again becomes a dome shape. You can see that illustrated in these two pictures here on the right side of your screen. For inhalation, the diaphragm flattens or goes down, and when it relaxes, it turns back into that dome shape. In healthy individuals, the airway automatically stays open. An injured or seriously ill person is not able to protect their airway, so it may become blocked. You must check the condition of the patient's airway and correct any problems to keep that patient alive. Check for responsiveness. Determine whether the patient is responsive or unresponsive by asking, "Hey, can you hear me? Are you okay?" If there is no response, gently shake the patient's shoulder and repeat your questions. Sometimes pinching a little bit of skin on their sternum or pinching their nail bed on their fingertip can elicit some type of response. If the patient is unresponsive, call 911 first before doing anything for your patient, or if you've been dispatched by a 911 system, get on your radio or your other communication device, contact dispatch and advise them of what you have, maybe asking for an advanced life support unit that's not already on the way, or additional resources. After calling 911, position the patient by, or contacting your comm center, position the patient by supporting the patient's head and neck and placing the patient on his or her back. Remember, they're unresponsive. At this point, we can't take a history or collect a history from them, so we have to assume that they would have a spinal injury until otherwise proven, or until proven otherwise. An unconscious patient's airway is often blocked by the tongue because it is dropped into the back of the airway, obstructing it. Simply opening the airway may enable the patient to breathe spontaneously on their own. The head tilt chin lift maneuver is a good way to open the airway when you do not suspect spinal injury. Place the patient on his or her back, kneel beside the patient, place one hand on the patient's forehead, and apply firm pressure backward with your palm. Place the tips of your fingers of the other hand under the bony part of the lower jaw or chin, or near the chin, and lift the chin forward to help tilt the head back. In the event that you are uncertain of spinal injury or you suspect spinal injury, you would want to use the jaw thrust maneuver. Use this technique. To use this technique, place the patient on his or her back while protecting the spine and kneel at the top of the patient's head. Place your fingers behind the angles of the patient's jaw and move the jaw forward with firm pressure. Tilt the head backward to a neutral or slightly sniffing position. Use your thumbs to pull down the patient's lower jaw, opening the mouth enough to allow breathing through the mouth and nose. After you have opened the patient's airway, look inside their mouth to see if there's anything blocking it. Potential blockages can include secretions, vomitus, blood, foreign objects such as candy, food, or dirt, dentures and false teeth, and sometimes medication patches. If you find anything in the patient's mouth, remove it using a tool and not your fingers. Tools such as McGill forceps, Yonker suction tips, or a wooden tongue depressor, as opposed to your fingers. Using your fingers will causes a high potential for injury to yourself, finger entrapment, and in some extreme cases, finger amputation. If the patient's mouth is clear, consider using one of the airway adjuncts described later on in this chapter. Using finger sweeps to clear the patient's airway of vomitus, mucus, blood, and other foreign objects can be done, though not recommended, as long as you're not inserting your fingers beyond their teeth or further into their mouth beyond their teeth. Suction machines can be helpful in removing secretions such as vomitus, blood, and mucus from the patient's mouth. There are manual suction devices. These are relatively inexpensive and compact enough to fit into an EMR life support kit. Suction tip, or insert the suction tip into the patient's mouth and squeeze the pump or hand-powered pump. Mechanical suction devices use either a battery-powered pump or an oxygen-powered pump aspirator to create a vacuum. Such a device draws the obstructing materials from the patient's airway. Turn on the suction device and use the rigid tip to remove the most of the remaining material. Do not suction an adult for more than 15 seconds at a time, or a child for 10 seconds. An infant as low or as short as 5 seconds. Because the suction also draws air out of the patient's airway, this can also stimulate what's called the vasovagal response and slow the patient's heart rate down. For unconscious patients, you must continue holding the patient's head to maintain the head tilt, chin lift, or the jaw thrust maneuver or position. If the patient is breathing adequately, you can open the airway by placing the patient in the recovery position. And you can also insert an oral or a nasal airway to keep the patient's airway open. So here on the left, we have an example of the modified jaw thrust maneuver. And then on the right, this is a depiction of a patient being placed in the recovery position. The recovery position. If an unconscious patient is breathing and the patient has not suffered trauma, place them into the recovery position. It helps keep the patient's airway open by allowing secretions to drain out of the mouth instead of draining into the trachea. It uses gravity to help keep the patient's tongue and lower jaw from blocking the airway. So circling back to those airway adjuncts that we mentioned a few minutes ago, you have two primary purposes with an oral airway. It maintains the patient's airway, and it functions as a pathway for suctioning. Oral airways can be used for unconscious patients who are breathing, are in respiratory arrest, or do not have a gag reflex. These airways can be used with mechanical breathing devices such as a pocket mask or a bag valve mask. There are two styles of oral airways. One style has an opening down the center, much like a tube. You'll see that in the photo here on your screen. And then there's another style that has a slot on each side, almost makes the shape of an I or a capital I. Same general curved shape as you see there in that picture. Before you insert the airway, you need to select the proper size. Choose the proper size by measuring from the patient's earlobe to the corner of the patient's mouth, from end to end of the oral airway. We have nasal airways. This device is inserted into the patient's nose. Nasal airways can be used in both unconscious and conscious patients who are not able to maintain an open airway. Nasal airways are not as likely to cause as oral airways to cause vomiting. You cannot suction through a nasal airway, though. Be sure to select the proper size of nasal airway for the patient. Measure from the patient's earlobe to the tip of the patient's nose, and that is from one end to end of the nasal airway. Coat the airway with some water-soluble lubricant before inserting it, such as KY jelly or Surgilube. The airway is fully inserted when the flange or the trumpet rests against the patient's nostril. So this side, it goes in first, this distal end with the bevel, and this is the flange up here that will be resting on the outside of the patient's nostril. After you have checked and corrected the patient's airway, you will next need to check and correct their breathing. Signs of adequate breathing. Use the look, listen, and feel techniques to assess If an unconscious patient is breathing adequately, look for rise and fall of the patient's chest. Listen for sounds of air passing in and out of the patient's nose or mouth. And feel for air moving on the side of your face when you're looking and listening. Normal adults have a resting breathing rate of approximately 12 to 20 breaths per minute. One breath includes both inhalation and exhalation. Signs of inadequate breathing. Noisy respirations, wheezing, or gurgling indicate a partial blockage or a constriction somewhere along the respiratory tract. Rapid or gasping respirations may indicate that a patient is not receiving adequate amount of oxygen as a result of an illness or an injury. The patient's skin may be pale or even blue. Most critical signs of inadequate breathing is respiratory arrest, which is characterized by 3 signs: lack of chest movement, lack of breath sounds, and lack of air against the side of your face when you feel. Causes of respiratory arrest can include, or do include, among other things, heart attacks, mechanical blockage or obstruction caused by the tongue, vomitus, particularly in a patient who's in a weakened conditions by something such as a stroke, foreign objects such as broken teeth, dentures, balloons, marbles, pieces of food, hard candy, especially in small children, some sort of illness or disease, drug overdoses, poisoning, severe loss of blood, electrocution by an electrical current or lightning. Check for the presence of breathing, or checking for the presence of breathing. Your assessment of any motionless patient begins by checking for responsiveness and assessing for breathing. If a patient is responsive in breathing, assist him or her as needed, if needed. However, if a patient is unresponsive, you need to determine if the patient requires assistance breathing or other interventions. While checking to see if a patient is responsive, look for signs of breathing by visualizing the patient's chest and observing for visual movement. As you perform rescue breathing, keep the patient's airway open. You'll want to pinch the nose, take a deep breath, and blow slowly into the mouth for 1 second. Remove your mouth and let the lungs deflate. Breathe for the patient a second time. After the first 2 breaths, breathe once into the mouth every 6 seconds. Mouth to mask rescue breathing. This enables you to perform rescue breathing without a mouth-to-mouth contact. This reduces the risk of transmission of infectious diseases. A lot of EMRs, EMTs, and other emergency services professionals will carry mouth-to-mouth vapor barriers, but typically we have equipment that enables us to not have to resort to mouth-to-mouth. Mouth-to-mouth rescue breathing, this technique requires no equipment. There is a somewhat higher risk of contracting a disease when using this method. To perform this method, follow these steps. Open the airway with the head tilt chin lift maneuver or the modified jaw thrust. Pinch the patient's nostrils together with your thumb and forefinger. Keep the patient's mouth open with the thumb of whichever hand you are using to lift the patient's chin. Take a deep breath and then make a tight seal by placing your mouth over the patient's mouth. Breathe slowly into the patient's mouth for 1 second. Remove your mouth and allow the patient to exhale passively. Repeat this rescue breathing sequence 10 to 12 times per minute for adults and about 12 to 20 times for children and infants. The bag valve mask device has 3 parts: a self-inflating bag or reservoir, one-way check valves, and a face mask. To use this device, place the mask over the face of the patient and make a tight seal. Squeezing the bag pushes air through a one-way valve through the mask and into the patient's mouth and nose. As the patient passively exhales, a second one-way valve near the mask releases air. The bag valve mask delivers about 21% oxygen without supplemental oxygen attached. However, supplemental oxygen is usually added to the bag valve mask device. When you are a first responder on scene, oftentimes you'll want to initiate respirations or ventilations with just the bag valve mask first and then attach oxygen later. A single rescuer may find it difficult to maintain an adequate seal between the patient's face and mask with one hand. Use of a bag valve mask device is best accomplished with 2 people operating if additional rescuers are present. So let's do a little review on the airway. You want to check for responsiveness by shouting, "Are you okay?" and shaking the patient's shoulder, trying to elicit some sort of response. If the patient is unresponsive, activate further EMS. Place the patient on his or her back while protecting the spinal column. Correct a blocked airway by using the head tilt chin lift maneuver or the jaw thrust maneuver. Check the mouth for any secretions, vomiting, or solid objects if found. Clear the mouth using tools, not your fingers. Correct a blocked airway if needed by using finger sweeps or suctioning to remove foreign substances. And maintain airway by manually holding it open or by using an oral or nasal airway. Remember, with breathing, we want to check for presence of breathing while determining the responsiveness of our patient. Correct the lack of breathing by performing rescue breathing using a mouth to mask or a mouth to barrier device if available. Rescue breathing for children. Children are smaller and you will not have to use as much force to open the airways and or tilt their heads. Give 1 rescue breath every 2 to 3 seconds, about 20 to 30 rescue breaths per minute. And then rescue breathing for infants. An infant is tiny and must be treated extremely gently. Placing padding under the infant's shoulders may help open the airway, as oftentimes infants, proportionately, their heads are larger than the rest of their body. And allowing them to lay flat on their back, the back of their head will actually kink their neck and sometimes block off their airway. Give rescue breaths or puffs enough to just see the chest rise and fall. Infant tidal volume is extremely small and is easily overventilated by adults. Most common airway obstruction is the tongue. If the tongue is blocking the airway, head tilt chin lift maneuver or the jaw thrust maneuver should open it. If a foreign body is lodged in the air passage, you must use other techniques. Food is the most common foreign object that causes airway obstructions. Children may put small objects in their mouth and inhale such things such as tiny toys or balloons or pieces of candy. Vomitus may obstruct an airway of a child or an adult. One risk of using your fingers in a child or an infant, as you can see here where this obstruction example is that when you stick your finger into the airway, though they may not have the strength to actually be able to harm you too much, you run a high risk of actually pushing that obstruction further down into their airway. So first, ask the patient, are you choking? If a patient can reply, the airway is not completely blocked. If a patient cannot speak or cough, the airway is completely blocked. Mild obstruction, airway obstruction, patient coughs and gags. The patient may even be able to speak, although with difficulty. To treat a mildly obstructed airway, encourage the patient to cough. If they are unable to expel an object by coughing, you should arrange for the patient's prompt transport to an appropriate medical facility. A severe airway obstruction, the patient is unable to breathe in or out, and because he or she cannot exhale air, speech is impossible. Other signs and symptoms may include poor air exchange, increased breathing difficulty, a silent cough, loss of consciousness in 3 to 4 minutes. Currently accepted treatment for a conscious patient involves abdominal thrusts, better known as the Heimlich maneuver. Abdominal thrusts compress the air that remains in the lungs and ideally forces the object out. When taking a look at how to manage an airway that we have either a confirmed obstruction or a highly suspected obstruction, starting in an adult, if the patient is conscious and we have confirmed that they are having an airway issue, if we will stand behind them if they're standing, or if they're sitting, we will crouch down or kneel down behind them in the chair, wrap our arms around them, and perform abdominal thrusts in the Heimlich maneuver fashion. If that person or patient becomes unresponsive, from a standing position, we will lower to the ground with the patient while holding on to them, so as to avoid causing any further injury to that patient. Or if they're in a chair, we will maneuver the patient's body out of the chair and lay them on the ground in a supine position and start performing CPR. For a child with an airway obstruction, it's pretty similar. We will do abdominal thrusts in the Heimlich fashion with a conscious patient who has an airway obstruction. And then, of course, when the child becomes unresponsive, if we are standing or kneeling, we will lower them to the ground in the supine position and perform CPR for 5 cycles before activating EMS if you are by yourself. If you are not by yourself, you will send a bystander to go activate the EMS system or 911 system while you continue CPR. For infants, if the infant has an audible cry, the airway is not completely obstructed. Using visual confirmation or inspection of the airway at this point would be appropriate. If you see an obstruction that you can easily get out of an infant, go ahead and do so. If it's farther back in the airway, it may be difficult. It may be an unnecessary risk to try to do a finger sweep, the risk being causing that obstruction to go further down into the airway and becoming further lodged. If this is the case, use a combination of back slaps and chest thrusts. Always start with the back slaps with the head lower than the rest of the body. That way gravity can assist that obstruction out of the airway. And then when you turn the infant onto their back and perform the chest thrust, again, you want the head lower than the rest of the body so that gravity can assist. If the infant becomes unresponsive, ensure that the EMS system or 911 system has been activated and begin CPR. Continue CPR until more advanced EMS personnel arrive or somebody at your level or higher can take over. So let's take a look at oxygen equipment. Oxygen cylinders are compressed oxygen up to 2,000 psi, and they're stored in portable cylinders of various sizes. Some of the sizes, the most common sizes that you'll see in the EMS system are D and E cylinders. There are also M cylinders that have their own sizing category as well. Various sizes, but these are the most common that you will see. Depending on the flow rate of each cylinder, they should last you approximately 20 minutes. Looking over here on the left side or the right side of your screen, is a pressure regulator or flow meter. It's a single unit that is attached to the oxygen cylinder, and it can be adjusted to deliver oxygen at a rate of 2 to 15 liters per minute. Now, these do have variations. Some regulators can actually go from 1 all the way up to 25 liters per minute, and you will see those occasionally on ambulances and first response vehicles. In earlier models, there is a O-ring or a wafer gasket that will ensure a tight seal between the valve stem on the bottle and the regulator itself. More modern systems actually use a inserted or in-seated brass wafer, which these removable discs are no longer applicable. Nasal cannulas and oxygen face masks. These devices ensure that oxygen is delivered to a patient and is not lost. Nasal cannulas are used to deliver a medium amount of concentrations of oxygen. Somewhere in the range of 24 to 44% oxygen is delivered into the patient's body. The face mask is placed over the patient's nose and mouth and to deliver oxygen through the patient's mouth and nostrils. And then we have non-rebreathing masks, which is the most commonly used face mask, oxygen face mask for EMS providers. So some safety considerations. Oxygen actively supports combustion. It is not combustible or flammable, but in mixture with other ingredients can help accelerate combustion or flames. It can quickly turn a small spark or flame into a serious fire. Remember also that these cylinders are always under pressure as well, which the rapid expulsion of that pressure can result in some sort of explosion or projectiles. All sparks, heat, flames, and oily substances must be kept away from oxygen equipment. In mechanical industries with welding and metal fabrication and things like that, or other diesel mechanics and things, when swapping out oxygen for cutting torches and things like that, we always make sure that the tops of the bottles are clean and dry from any kind of oil or residues before swapping those regulators out, just to reduce the risk of there being any ignition of a substance that might be resting on the outside of that bottle. Obviously, smoking is never safe around oxygen equipment. I've been to several calls where somebody was sitting in their living room or in their recliner with a nasal cannula in their mouth, kind of a dusty, dirty environment, smoking a cigarette. And the combination of that dust, dirt, dander, what have you, floating in the air, an ignition source, and the oxygen causes a flare-up of flame, usually causing burns around the mouth, nose, and rest of the face. Sometimes the hand, sometimes it even caught the furniture on fire or the clothing that the patient was wearing, causing further burns on other parts of their body. High pressure in an oxygen cylinder can cause an explosion, as I've just mentioned, if the cylinder is damaged. Oxygen cylinders should be kept in sturdy carrying cases and should be handled with care to guard against any damage or dropping. Storing these cylinders at your department or base or headquarters, they should be in locked containment cages, and we typically, just for tracking purposes, usually separate them into full categories and empty categories. So administering the supplemental oxygen. First, we want to assemble our equipment. So we'll place the regulator over the stem of the oxygen cylinder. Here you can see a little green cap covering the orifice of where the oxygen is going to come out of that valve stem. And that's just a protective dust cap. So we will remove that first, slide the regulator over the valve stem. I'll back up a couple slides here so you can see what it looks like here in your upper left-hand corner is once it's assembled. And then down here in the right-hand corner is a closer view of that. So we're going to use that toggle corkscrew or turn screw to tighten the regulator down firmly to the valve stem. Hand tightness only. You don't have to get a wrench on it to over tighten it. That's really not needed. Turn the cylinder valve 2 full turns, which is right here where you see in between this person's fingers. We usually have what's called an oxygen wrench or an O2 wrench. That is a slightly oval-shaped stem, so it takes a specific type of key. A lot of times you can use a pair of pliers, or trauma shears will actually have a cutout in them that will fit over that stem to allow you to be able to turn it when you don't have an actual O2 wrench or oxygen wrench. Then, of course, you're going to want to check the gauge on the pressure regulator, make sure that the previous crew has actually fully turned off the valve stem or replaced the bottle when they depleted it. Make sure that you have enough oxygen in there to actually use. And then adjust your flow meter to deliver the desired liter per minute flow, depending on what type of oxygen delivery method you're using, whether it be a face mask, non-rebreather, or nasal cannula. When the oxygen begins to flow, place the mask or the nasal cannula onto the patient's face. Do this first. Have the oxygen flowing before putting it on the patient's face, as opposed to putting it on the patient's face and then turning the oxygen on. With face masks and non-rebreathers, it creates a smothering sensation and decreased amount of oxygen while there is not oxygen flowing through that that system. And then with nasal cannulas, though you're not decreasing the available oxygen to the patient, it does create a very uncomfortable and concerning puff of air, an uncomfortable puff of air going into their nasal passage when you turn the oxygen on. So the nasal cannula, it is designed to deliver a flow rate of oxygen at 1 to 6 liters per minute. Anything higher than 6 is kind of turning you into a wind tunnel, or your nose into a wind tunnel. The concentration is generally between 24 and 44% oxygen. So adjust your flow rate first. Usually what I'll do is I'll just kind of take my index finger, and run it over the tips of the nasal cannula prongs just to make sure I can feel that the oxygen is actually flowing before putting it onto the patient's face. Non-rebreather masks is the other most common oxygen delivery method, as opposed to a simple face mask. These are designed to deliver a higher flow rate of oxygen between 8 to 15 liters per minute and can deliver concentrations of oxygen as high as 90%. These should be used for patients who require higher flows of oxygen, experiencing respiratory distress, trauma victims, things like that. Chest pain, carbon monoxide poisoning, congestive heart failure, fluid in the lungs, and then signs and symptoms of shock. For this, we will turn on the oxygen, select our desired flow rate, somewhere between 8 and 15 liters per minute, place the mask over the patient's face, and then adjust these green straps, which is simply an elastic band that goes through a hole that is just ever so slightly smaller than the band itself. So they kind of hold that band snugly. That band goes around the back of the patient's head. You pull the tabs to adjust the tightness, and then adjust the flow leader to keep the bag off the non-rebreather at least partially inflated. It's okay for it to be fully inflated, and it's actually okay if when the patient is breathing that they actually suck that bag dry or completely flat, because when they exhale, the oxygen will refill. During the exhalation, the oxygen will refill that reservoir. Another thing that I should mention, when you're setting up your non-rebreather, you turn your oxygen on to, say, 12 liters per minute. Take your thumb of one of your gloved hands and cover this little one-way flapper valve in here for just a couple seconds. And what that does is it quickens the filling of the reservoir bag, and it helps you also ensure that there is oxygen flow in the mask before putting this on the patient's face. So what are some hazards of supplemental oxygen? Well, supplemental oxygen must be used carefully. We all know that, so that you, your team, and your patient will remain safe and burn-free. You will need additional classwork and practical training before you're ready to actually administer the oxygen, which we will do in one of our clinical labs. This picture shows an example of an oxygen cylinder that looks like it probably levied or ruptured, possibly during a house fire or something like that, or car accident. There's no telling on what caused that rupture, but that's kind of what it could look like. Essentially, these are little pipe bombs that people carry around in their shoulder bags or fanny packs, or in little O2 caddies that live in their houses with them. So pulse oximetry is a useful tool, but not a definitive tool. Pulse oximetry is used to measure the amount of oxygen saturation in the red blood cells. A pulse oximeter consists of a sensor probe and a monitor. To operate the pulse oximeter, turn it on. Put it on the finger. You want to place the sensor probe, or the little light that's inside the probe, directly over the patient's fingernail bed or fingertip, or their earlobe if you have that type of probe. There are probes out there now that have adhesive glue that allow you to actually tape it to the patient's earlobe, their finger, their toe, and in some of our smaller infants, they can actually go around the foot or the hand to help pick up that oxygen saturation. In a healthy patient, we're looking for between 94 and 100% oxygen saturation when they're breathing room air. Obviously, we put them on supplemental oxygen, that percentage is going to go higher, or ideally will go higher. If the patient is having difficulty breathing as a result of an injury or a disease process, the percentage of oxygen may be much lower than 90%. This would be a good indication that they would need oxygen. Keep in mind that pulse oximetry cannot tell you what is wrong with the patient, but it can help you recognize if the patient is having a problem and determine whether your treatment is helping the patient or not. It does have certain limitations, however. It will not give you an accurate reading if the patient is wearing nail polish or if the patient's fingers are very dirty, wet, or cold. With the nail polish, the quickest and easiest way I found is turn the probe sideways or to 90 degrees on the patient's finger, and you can get a fairly reliable capillary reading. For cold or wet fingers, obviously wet, we just dry them off. For cold fingers, what I'll personally do is I will take that patient's hand and wrap them in between my hands for 10 to 20 seconds, kind of warm those digits up, and then I'll place the pulse oximeter on the patient's finger. With those warmed capillaries, it increases the blood flow, and you get a much more accurate reading. Some people have peripheral vascular disease or just generally poor circulation. Sometimes in the winter when it's cold, their digits get cold from being exposed to the temperatures. So there's all kinds of reasons that can throw the readings of your pulse oximeter off. Patients who have lost a lot of blood will have inaccurate readings. Trauma patients and patients who have experienced carbon monoxide poisoning will have false readings as well. One thing to remember about pulse oximetry is that it's a tool, and it only picks up the percentage of oxygen in your blood, and it cannot tell you the percentage of carbon monoxide in your blood. So a patient who has been exposed to a house fire or other sources of carbon monoxide can still have an adequate oxygen saturation, but their blood system can be inundated with the carbon monoxide that we cannot detect. So therefore, paying attention to the signs and symptoms and the presentation of the patient and reading that in conjunction with our diagnostic tools is very important. So rescue breathing for patients with stomas. Check every patient for the presence of a stoma. Wintertime is especially. Even during the summer, people with stomas like to wear scarves when they're out in public, or something to kind of cover that stoma up so it's not as visually present. If you do locate a stoma, try to keep the patient's neck as straight as you can. Some of these people have had surgery to remove part of or all of their larynx. In these patients, the upper airway has been rerouted to the opening, which is now the stoma, or the hole in the neck. It's always going to be on the front of the neck. And when rescue breathing must be given through a stoma, it is a technique known as mouth-to-stoma breathing. So if you locate a stoma, keep the patient's neck straight, examine the stoma, clean out any mucus in it, suction if necessary. If there is a breathing tube in the opening, remove it to be sure that it is clear. And then in the absence of proper equipment, life or death situation, place your mouth directly over the stoma and use the same procedures as in mouth-to-mouth breathing. If the patient's chest does not rise, cover their mouth and their nose or seal it with one of your hands, your free hand, and then breathe through the stoma again. Obviously, or ideally, we're going to be on shift when we're presented with these situations, or at least have a first responder bag with us. So we should at least have a mouth-to-mask or a pocket mask with us. For using a bag valve mask or a pocket mask device on a patient with a stoma is very similar. You just take the mask itself, cover the front anterior portion of the patient's throat, making sure that you're actually covering the stoma, and then ventilate. If you have no chest rise or fall, you can try covering their mouth and their nose with your free hand to try to stop air from escaping back out through their mouth or nose. If you have leakage, air leakage around the mask, just like when we're doing normal ventilation through a bag valve mask over the nose and the mouth, we'll just readjust that cuff on the mask to kind of occlude those leaks. So back to this slide, gastric distension. This occurs when air is forced into the stomach instead of the lungs. It often occurs during CPR. It does increase the chance that the patient will vomit or aspirate. So we want to breathe slowly into the patient's mouth instead of fast, large puffs or bursts of air. That increases the likelihood that, yes, air goes into the lungs, but you're also forcing air past the larynx, or the glottis, into the patient's stomach. And every time, even though it's a small amount, every time that happens, there's nowhere for the air in that stomach to go except to build up and build up and build up. So we want to breathe slowly through the patient's mouth or stoma, just enough to make the chest rise and fall. As soon as we see that chest rise, we stop. We back away. We allow for the passive exhalation of the patient. Dental appliances. So do not remove dental appliances that are firmly attached. If they're firmly attached and where they're supposed to be, not a problem. They may actually help keep the patient's mouth full or in a proper anatomical formation so you can make a better seal. If you have dentures or other dental appliances like false teeth or individual teeth, partial dentures, full dentures that become dislodged and are free floating in the mouth, we want to remove those. One, they could occlude the airway in a couple different ways, and then they could also cause sealing issues for us when we're trying to ventilate. So again, going back to a previous chapter, we don't want to stick our fingers inside that patient's mouth. Even if they don't have teeth, they still have jaw bones. If their body decides to reflexively clamp down, that's a lot of pain and a lot of tissue damage that we want to avoid. So we want to remove those with some kind of mechanical tool or device, McGill forceps, tongue depressors. If you can grab them with a suction catheter or a Yonker suction tip, if your device has enough suction power to grab onto them, that's great, or something like that. Another method, if you don't have any tools, is you can roll them into the recovery position and see if gravity will help those items come out of their mouth. So up until now, we've talked about managing an airway with a person that's presumably in a residence or in a room or some other public place like a park or something like that, where they are either standing, sitting, or already laying flat on the ground. Now let's talk about managing an airway of a person that is in a vehicle. So typically, we're going to use the jaw thrust maneuver for a patient who's laying on a floor or in a seat that we don't know if there's been some sort of traumatic injury, and we don't really have a history of that patient, so we want to protect their spinal cord as best as possible. Same thing for victims in a car. If we can't see inside their body, so we don't know if there's spinal injuries, we're going to try to use the jaw thrust maneuver if possible. Sometimes, due to the nature of the accident and deformity of a vehicle or what have you, we may simply not be able to do that, and we just have to adapt and improvise the best we can. When the patient is sitting or semi-reclining or in a semi-reclining position, we'll approach them from the side, usually the side of the vehicle that they're in, lean through the window or across the front seat. We'll grasp the patient's head with both hands. This is also presuming that they are unconscious. If they are conscious and can talk to us, they probably don't have an airway issue. So then we're going to coach them and try to direct them, to try not to look left or right or up or down. Just try to follow my commands, move as little as possible until we can get your spinal cord protected. So back to the jaw thrust. Grasp the patient's head with both hands. Move one hand under the patient's chin and the other on the back of the patient's head just above the neck, about the base of the skull. Maintain a slight upward pressure to support the head and the cervical spine. This technique does have several advantages. You do not have to enter the vehicle if you can easily access the patient's head and airway. You can easily monitor the patient's carotid pulse and breathing patterns with that lower hand that's underneath the jaw by using your fingertips. You can also feel with your hand any air movement coming out of their nose or mouth. And this technique also stabilizes the cervical spine and allows easy access for other responders to help begin immobilizing and removing the patient from their seat. And of course, it does what it's intended by opening the patient's airway. All right, so let's sum it all up. We've covered in this PowerPoint, or this lecture, the main purpose of the respiratory system is to provide oxygen and to remove carbon dioxide from the red blood cells as they pass through the lungs. When a patient experiences possible respiratory arrest, we check for responsiveness, open a block airway using the head tilt chin lift or the jaw thrust maneuver, check for fluids, solids, or dentures in the mouth, correct airway if needed. Using finger sweeps, not so much anymore, or suction or other mechanical tools to clear that airway. Maintain airway by continuing to manually hold open the airway by placing the patient in the recovery position, which is that left laterally recumbent position, or laying on their left side, and then inserting an oral fairway or nasal pharyngeal airway. If the airway is obstructed in a conscious adult or child, kneel or stand behind the patient and perform the Heimlich maneuver, depending on the position they're in. Administering supplemental oxygen to patients that show signs and symptoms of shock increases the amount of oxygen delivered to the cells. Also, keep in mind, on a side note for that one, just because their body globally may not need oxygen, there may be a certain portion of their body that needs that increased level of oxygen as well. Like the cardiac tissue in the event of a heart attack, or the brain. Those are some very important things that, though the rest of the body might be adequately being perfused and oxygenated, those portions of the body may be deprived of that oxygen and need that increased level. Pulse oximetry is used to assess the amount of oxygen saturation in the red blood cells and is used as a diagnostic tool and not a definitive diagnostic tool. So we have a couple review questions here, or a few review questions. First one is, after opening a patient's airway who has a pulse but is unconscious, you should, is it A, perform a blind finger sweep, B, immediately attempt to insert an oral airway or an oral pharyngeal airway, C, check for secretions, foreign bodies, or dentures, or D, perform CPR. The correct answer for that one is C. Check for secretions, foreign body obstructions, or dentures. Question number 2. You should place a patient in the recovery position to, is it A, prevent the patient from going into respiratory arrest, B, allow secretions to drain out of the mouth, or C, protect the patient's spine from injury, or D, to facilitate the administration of supplemental oxygen? The correct answer for that one is B, allow the secretions to drain out of the mouth and let gravity work with you. Question number 3. The pulse oximeter is used to, is it A, assess the amount of oxygen saturation in the red blood cells, or is it B, provide supplemental oxygen to the patient, or C, assess how much oxygen the patient requires, or is it D, eliminate carbon dioxide from the bloodstream? And of course, the answer on that one is going to be A. It assesses the amount of oxygen saturation in the blood cells. All right, so that is it for Chapter 7. We will be covering Chapter 8 in our next clinical session on Saturday. That'll be a live presentation, but in the meantime, go back, review your Chapter 7. Of course, pay attention to your learning objectives for this chapter. There's a lot of them, but they are good good suggestions on things that we need to study. All right, thank you very much for tuning in, and if you have any questions, feel free to email me or drop the question in the classroom chat, and we'll see you next time.